We feel that it was important to conduct this study because not much is known about the real-world use of the novel anticoagulants. The four landmark clinical studies that compared warfarin to the novel anticoagulants were very well designed, but the impact of real-world use and the effect of real-world use of these medications is not well known. So we went back and we looked at a large number of patients. We got our data from market scan database, which have claim-based information for over 80,000 patients on both Medicare and private insurance. So this was a retrospective study comparing in real world, in real life, the use or the complications and the side effects of using warfarin and using the novel anticoagulants. More importantly, we wanted to see the effect of adherence on the treatment success or failure of these medications. And as I mentioned earlier, this is a market scan database. This is a company that collects claim data on patients who are Medicare and private insurance patients. The findings were very interesting. What we found is that about anywhere between 25 to 30% of the patients were non-adherent to taking NOACs or anticoagulation in general. So when we looked at the outcome, for example, of ischemic stroke, we found that patients on warfarin did little better than patients on NOACs. And this was a surprising finding. When we looked at hemorrhagic strokes, the patients on NOACs did better. When we looked at a combined stroke, ischemic and hemorrhagic, the patient with warfarin did better. This was also surprising. And when we looked at bleeding in general, patients on NOACs did better. So why is that? Why is that slightly different than the results of the clinical trials? We believe this is mostly due to adherence. So you may say, okay, why adherence affects Coumadin or warfarin more than NOACs? Okay. We believe because of the short action nature of NOACs, they may be more prone to bad effects of lack of adherence compared to warfarin. Because of the long-term action of warfarin, it may be a benefit, not a benefit, to provide like a buffer if you miss one dose of warfarin comparing to missing a dose of NOAC. You ask about the implication also. So the implications are important here because this tells us that maybe we need to educate these patients who we suspect having a non-adherence issue with the NOACs. So maybe establishing an anticoagulation clinics similar to the anticoagulation clinics for warfarin, establish anticoagulation clinics for NOACs. These anticoagulation clinics, I'm not proposing to have anticoagulation clinics on everyone who's on NOAC, but maybe identify a high-risk group of patients who are having some features who we know which patient will not take that blood thinners on a regular time or regular schedule, and focus on these patients to enroll them in anticoagulation clinics. We have data now we need to know what to do with. I think we need to pay attention to the adherence issue and work hard to try to reduce the number of patients who are not adherent with their medication. But also, we have other options other than anticoagulant. Maybe we can provide solution to patients who are non-adherent to non-pharmacological options, such as left atrial appendage closure. We'd like to look into why patients are non-adherent with the medications and what kind of interventions we can do to increase the adherence of patients for taking their medications.